So the patient was a 66-year-old man with no traditional risk factors, had history of angina, rest angina 2 weeks prior to presentation, and class 2 exertional angina. The ECG showed dynamic SGT changes. The cardiac troponin was negative, and the echocardiography showed normal LV function without any regional wall motion abnormality. The patient was diagnosed to have non-ST elevation ACS, unstable angina. And this was the initial coronary angiogram. As we can see here, there is the AP caudal view and the orthogonal AP cranial view. And analyzing this angiogram in detail, we can see there's a proximal aneurysmal segment in the LAD. There is a distal aneurysmal segment, and there's a tight stenosis between the two. The ostial LAD looks fine here. There's also a significant lesion in the major obtuse marginal, but we are talking about the LAD lesion in the present discussion. So this is the intravascular ultrasound pullback. We didn't go very deep into the LAD, starting right near the diagonal. As we can see here, this is the distal aneurysmal segment, just proximal to the diagonal. We'll have the stenotic, the tight stenotic lesion coming up now. So there is some calcium, there is attenuated plaque, and then we have another segment which is also aneurysmal. So it's more than 1.5 of the proximal reference. Aneurysms tend to occur between tight stenosis, so it is important to look at the status of the proximal, osteoproximal LAD. So this is the aneurysmal segment, which is 6 mm, and just distal to the ostial LAD, and ostial LAD looks fine. And now we are going to come into we have the circumflex ostium and the left main, which is all good. So analyzing this intravascular ultrasound stepwise, we have the mid LAD just at the level of the diagonal, which looks healthy. There's a distal aneurysmal segment here, a luminal diameter of 4.5. We have the stenotic segment, which has calcium with acoustic reverberations and attenuation as well. So it's a lipid-rich plaque. Makes sense, the patient presented with ACS. We have the proximal aneurysmal segment, and we have the most proximal part of this aneurysm, which is very large, 6 mm in diameter. The ostial LAD is fine, and the distal left main is fine. So what are the options that we have for such a case? So we could put a single drug-eluting stent right from the ostium to the mid-LAD, cover the aneurysm, but the problem is they'll be floating struts all the time. They're less likely to get endothelized, and there'll be a gross mismatch in the size compared to the aneurysmal segment. We could put a covered stent across the aneurysm, but covered stents, most of them, for example, the Graphmaster is a bare metal stent. There are 2 bare metal stents with the PTFE sleeve, and they are associated with worse outcomes. So we definitely, that's not the first option. We could put 2 or 3 drug-eluting stents and have them overlap in the aneurysmal segment, expecting that that would exclude the aneurysm. That is also one option, but we want to minimize the layer of metal. And so we decided that we'll go ahead with the focal stenting in the aneurysmal segment, guided by the IVUS with precise positioning, but this too, there are risks that we may slip while deploying, so we need to be careful. So our strategy was focal stenting guided by IVUS. So coming from distal to proximal, we have the distal reference marked 1 here. It is a luminal diameter of 4.5. The tight stenotic segment, which morphology-wise has some calcium, has higher attenuated plaque. We don't want to be very aggressive with pre-dilatation or post-dilatation because of distal embolism. And it is important to note in such a lesion that is there significant negative remodeling. So aneurysmal segments are large in size, but we don't know the actual reference. This is the stenotic segment. Here the media to media diameter is 4.5, so we should not exceed that when we are doing post-dilatation. And the proximal reference is also 4.5. So this is the objective analysis. We can see the two, this is the L mode showing this is distal, proximal, and we have large aneurysm here, and this is the area we wanted to stent. So we went ahead with the procedure. We did balloon dilatation with a balloon just to make room for the stent. We did an angiogram with the balloon to confirm our measurements. This is a 15 mm balloon. We positioned a 4.5 into 16 mm drug-eluting stent, mindful of the gap between the distal marker and where the stent starts. We wanted precise positioning. We deployed the stent, and this was the result after stenting. Clearly, there's under-expansion in the middle. We did post-dilatation with the 4.5 balloon. That was the medial diameter at the level of the lesion. We didn't want to exceed that. And this is the final angiogram. Looks like a step down at the distal edge of the stent. And let's see what the IVUS shows. Okay, the IVUS tells us that, so this is the distal, this diagonal. We wanted to place our stent just proximal to the diagonal. This is the diagonal, sorry, that was the septal diagonal. We have the stent, there is no distal edge dissection. The expansion in this aneurysmal segment looks good. We'll come to the lesion now. The lesion has well expanded with the good MLA. And proximal to the lesion, we have the proximal aneurysmal segment, which it is well expanded, and there is some malapposition with blood speckle behind the stent in the very proximal part, but we didn't want to mess around with this, and we've not entered the very large proximal segment with 6 mm diameter, and that was our objective, to limit our stent length and be focal. So this is the intravascular ultrasound analysis stepwise, and we can see there's no distal edge dissection, good expansion, acceptable luminal area, and slight malapposition in the proximal segment. And what are the learning points from this case? So intracoronary imaging can help in planning strategy in patients with coronary aneurysms which have stenosis. And the ultrasound has a higher penetration and can allow precise assessment of the vessel size in the stenotic segment. The stenotic segments with aneurysm may be associated with negative remodeling. The stent sizing has to be careful because we do not know the real reference diameters. And core registration is preferred, but is not easily available. We can use side branches like we use the diagonal side branch here. And the last point is that focal stenting is a feasible option for stenotic segments if guided by imaging. Thank you.